So there's two things that come to mind for needing visual correction. One is the size of the eyeball itself, so the axial length of the eye. A too long eye, a too short eye have optical ramifications that cause a need for spectacle correction, as well as the curvature of the front surface of the eye. Both of those things in concert either say, nope, you're good without glasses for quite a long time, or no, we actually do have to provide you some type of vision correction. So when it comes to both refractive surgery as well as orthokeratology, typically we're taking a curved cornea and we're flattening a little bit, and that can relieve some nearsightedness or some myopia.
Welcome to the IQ Podcast. I'm Dr. Ronnie Bannock, here to help you boost your IQ with powerful insights that connect your eyes, your brain, and your whole body wellness. Welcome to today's session. I'm your host, Dr. Ronnie Bannock, and today we are so honored to have with us Dr. Christopher Lievens, who is not only a seasoned optometrist, but he's also a very accomplished researcher in the eye health space. Thank you so much, Dr. Lievens, for joining us.
My pleasure, man. Thanks for having me.
Absolutely. Dr. Lievens, you actually wear several different hats. You're an optometrist, you're also a researcher, you have a PhD. Can you tell us a little bit about your journey in eye care and some of your research explorations?
So early on in practice, just as an independent optometrist, I practiced on the East Coast. I was in a 2-location, 3-doctor private practice. I was in an ophthalmology anterior seg practice, and I was in the United States Air Force for a few years. And the year 2000, I decided to go full-time into education. So for most of the time between the first 20 plus years of my academic journey, I taught a number of classes, as well as I oversaw all of our patient care in our main clinical facility. A number of years after that, though, I decided to pivot my career. Sometimes as you get older, you want to freshen things up. So I went on for a PhD in the UK and have been really doing research ever since. And so now at my academic institution, I am the director of research. And I researched the entirety of the eye from the cornea to the retina and everything in between.
That is phenomenal. And I'm so glad you took that little pivot. It's not a complete pivot, but a little kind of side detour to the research space. So I know a lot of your work, at least in the past, has focused on corneal health and contact lens technologies. Can you tell us a little bit about how contact lenses have changed over the decades?
Sure.
I know many people think of contact lenses as these uncomfortable devices they used to wear, but things have really evolved since then, haven't they?
Yeah, the research and development space in the realm of contact lenses has really exploded in the last quarter century, and it continues to even in the last few years. These lenses can fit the multitude of eyes, the multitude of ages very successfully, and that really wasn't always the case.
So what are some of just for our audience, an overview of the different types of contact lenses, because they're not all the same and they're not all for all purposes. So can you give us an overview of what may be appropriate for certain types of issues?
Sure. So starting with the most rare, there are certain contact lenses that are dedicated to certain ocular and anterior segment corneal, especially diseases. And there are some that can reshape the cornea to modify refractive error. And so those would typically be rigid lenses, often scleral designs, and they are very successful and they continue to advance in terms of their ability to fit normal eyes as well as abnormal eyes. But then as we migrate from there, most people in the world today who wear contact lenses wear soft contact lenses, those that correct a common refractive error. And then even if you have a little bit of astigmatism, and now as you're looking at me, I wear multifocal contact lenses. So as you become those 40-year and older eyes where you need reading glasses and bifocals and progressive lenses, wow, the advances there are really delivering phenomenal vision. And so when I really say from childhood to grave, I think off the top of my head, the oldest patient to date that was a brand new contact lens wearer that I fit was 87 years old.
Wow. So it's not too late for anyone, right? No matter
it's really not. And in that vein, there's an important add-on for those people out there or patients out there who maybe failed in contacts previously. Don't give up, because the science and technology has now brought it to the point where if you didn't succeed before, there's an excellent chance you could be a great candidate today.
That is such an important point, Dr. Lievens, because whenever I bring up contact lenses with my patients, some of them say, I tried it when I was a teen or in my early 20s. My eyes got so dry, it's just so I can't wear them anymore.
Right.
But what do you tell patients who say things like that, who've had
I
experience?
say, let me have a go at it, because I'm going to put you in a high technology lens, one of the newest to market in all likelihood. And if you have some dryness, of which honestly, I make most of my patients prove to me they don't have dry eye until I assume they do, because it's so prolific. In fact, one of our most common growing diagnoses is pediatric dry eyes. Just the tablets, digital devices that we use each and every day. What are we doing now? We're talking on a computer, virtual screen. Probably neither one of us is blinking appropriately. And so there are contact lenses that are aptly suited for eyes that have failed in the past, even for those that have diseases and even for those that have dryness issues.
So, walk us through what a typical visit with you would look like if you were going to consider a patient for contact lenses. What tests do they need to do before you would consider potentially fit them for a lens?
So probably the first and foremost is I have to get an idea that their eye is operating healthfully and they're seeing as well as they can. So I want to know, in spectacles anyway, what is the best they can see, because that gives me a reasonable goal to where I need to get to with contact lenses. Then I take a very comprehensive look at their ocular health to make sure that there's no contraindication for a contact lens or something that's going to throw me a curveball, say, along the way. And if both of those things hold true, I'm going to do a very precise refractive analysis, both at distance, now with computer vision, computer distance, as well as near vision, to have goals in mind for acuity at all those distances. And all this time, my wheels are spinning on what is the number one choice of lens in my mind for them. And I usually present them with the best first. Before talking about price and convenience and replacement schedules and cleaning and all that, I just put the best in their eyes and start there. Because if I'm successful, at least I know, okay, we have a great candidate sitting in front of me. Now it's just going to come down to what our final lens choice is going to end up being.
Got it. Now, are there specific types of patients in whom you would not recommend a contact lens? Can you think of some contraindications that you mentioned earlier?
For patients who have issues with chronic infection would be one. Chronic surface issues that are not resolvable just on their own or via medication, and any patients who have known allergy to a known component in the lens. However, usually all those things that I mentioned, there's a way to navigate around those. For example, on the allergic piece, we have some patients who are hypersensitive to silicone as a material on their body and in their eye. But we can pivot from there and go to a lens that doesn't have silicone in it. So there's usually a way around this. It's usually not a fail, but there are some things that pose some caution.
Since we're talking about allergy, there's this one condition, which is not so common, but when it happens, it can be debilitating, called giant papillary conjunctivitis. Right. And oftentimes it is related to contact lens use. Can you tell us a little bit about that condition?
Oh, yeah, we would see giant papillary conjunctivitis all the time. I'm talking in the mid to late 90s and certainly earlier than that, and then approaching in the early 2000s. Where the allergy to either just the environment or to the lens itself was so robust. Because you imagine if you have a bug bite, your tissue swells up. This happens on the inside of the eyelid. And so now you have an eyelid that's trying to blink over a contact lens, but instead of looking like a smooth pane of glass, it looks like a cobblestone street from the 1700s. It just doesn't work well, and the patient's incredibly uncomfortable. So now, but I will say, fast forward in time, this is a great example of how technology in health has a way to remedy and rectify some things that we previously dealt with. Because I haven't seen giant papillary conjunctivitis due to contact lenses in probably 25 years. So it may be out there worldwide, but it's not something that I've encountered in a very long time because technology has solved that problem for us.
Yeah, same here. I can't even remember the last time I saw a case. Maybe it was back in residency. Thank you for that. Even people who've had issues in the past may want to reconsider their choice of starting contact lenses again. You mentioned earlier, Dr. Lievens, about multifocal lenses. Now, I myself, I do wear them on occasion, not all the time, but I do wear them. Can you tell us about how that technology works and who it may be best for?
So it's really complicated. The optics of these lenses is no short of challenging. And it's the reason why it took so many years to come to the limelight, because the optics of these contact lenses have to be able to deliver light and bend light in certain ways to allow patients to see at all distances, regardless of their older years having difficulty focusing up at close. We all can imagine what a traditional bifocal lens, a spectacle lens is, where you look above the line, you see far, you look below the line, you see near, and those are just two different lens powers. Now, with a contact lens, we actually can have an infinite number of lens powers, where the lens is just slowly bending light throughout the entirety of the lens. There's no just look up and look down. It's just simultaneously, you can view all types of vision. So the science is really compelling that someone was actually able to invent this. In terms of who is it for, it used to be, I really didn't start talking about this to patients till they got in their mid 40s, late 40s per se. But the challenges of the amount, if we all counted the amount of minutes per day that we're doing something up close, now I start talking to people in their late 30s because they can really benefit from some additional power given the amount of time that they're using mental tasks up at close, where it didn't used to be that way.
Based on its name, multifocal, so that would that be appropriate for distance, intermediate, let's say computer vision and reading?
It's appropriate for all of those. It is optically correcting every single distance between optical infinity and where you would typically hold your phone.
And are there any drawbacks? Like, for example, I know when it comes to a different type of multifocal lens, for example, post-cataract surgery, there are these lenses that can be put into the eye. Sometimes they cause glare, sometimes they cause halos or distortions. Do these multifocal contact lenses also have similar side effects?
So even though the optical designs have some similarities between an intraocular lens and a contact lens, they are distinctly different and operate differently. The good thing about a contact lens, unlike an IOL, is I have the opportunity to go from different optical designs. So if choice A doesn't work, I can pivot to choice B, whereas post-surgery, that's a whole lot harder to get into. I will say though, as a prescriber, I definitely have my favorite. And in terms of my success rate on my favorite product, which just so happens to be the brand that I wear personally, my success, I think I can only recall failing on a patient one time in my entire career. And so I'm highly successful with this type of a lens. One of the things though to consider and let the patient know is there is a little bit of adaptation. So I typically will fit this lens to the best of my ability on day one, bring them back approximately a week later because I'll need to refine it a little bit. But what I found is there's some neurosensory adaptation that happens with this complexity of optics in the lens where they see great and they see great going home for that year. But when they come back the subsequent year and even the year following, I am going to continue to tweak that power. And I find that this neurosensory adaptation occurs where they will continue to see better from day 1 to day 7 to year 1 to year 2. So if they're happy at day 1, wow, I know I got them because they're only going to get better from there.
Yeah. So, you have a success case on your hands there. Yeah. Yeah. And I just wanted to share my experience with multifocals. And I started wearing them when I was in my early 40s. And initially it comes in various different powers, and you can explain this better than I can, but low, mid, and high add powers. So I started off with low, and then that worked for a few years. And then I had to upgrade to the next level, which was mid and high. But then at some point, even with the high lenses, I wasn't completely comfortable. So then my eye doctor helped me to switch to a different brand. And sometimes that makes all the difference, right? When you experiment with different ones, and maybe one brand works better than another.
I think that you bring up an excellent point because from the patient perspective, I think patients really need to be open and honest about what they love and what they're falling short of. Because a lot of times my patients say, "Oh, Chris, I'm doing fine." Fine, I don't want to know. I want to know exactly where I could improve, because there could be a very good chance where we can make a change, which could deliver improvements and really enhance quality of life and certainly vision as well.
Yeah. Thank you for those incredible insights, Dr. Lievens. It's so important. I'm sure many of our listeners their eyes will be opened to these possibilities. Right. We are going to take a very short break. We're going to hear from one of our sponsors, and we'll be right back.
Are dry, irritated eyes holding you back from enjoying your day? It's time to find relief with the Dry Eye Bundle.
Our all-in-one solution offers everything you need to combat dry eye discomfort. Soothe provides a complete blend of the omegas 3, 6, 7, and 9 to support healthy inflammatory responses and provide essential nourishment and lubrication for dry eyes. The patented Brooder Moist Heat Eye Compress helps to support your eyelids' oil glands, allowing natural oils to flow onto your eyes, relieving discomfort effectively. Our all-natural isotonic Brooder Hygienic Eyelid Solution delivers professional strength results without the hassle and cost of a prescription. Brooder Hygienic Eyelid Cleansing Wipes with tea tree oil provide targeted relief for dry eye associated with meibomian gland dysfunction and Demodex mite infestation. These wipes can help improve lid hygiene. Visit our website today at drronniebannock.com to get 10% off your first order. Give your eyes the relief they need with the Dry Eye Bundle.
Welcome back, everyone. Today we're chatting about contact lens options and contact lens safety with our expert, Dr. Chris Lievens. So next, Dr. Lievens, I wanted to ask you about this, I guess, relatively new type of lens called Ortho K.
Sure.
Can you explain what Ortho K is and who it's appropriate for?
So I guess the first thing I would start with is just to get everybody on this whole playing field of the whole reason why we have refractive error. And so in the case why I'm wearing glasses right now. So there's two things that come to mind for needing visual correction. One is the size of the eyeball itself, so the axial length of the eye. A too long eye, a too short eye have optical ramifications that cause a need for spectacle correction, as well as the curvature of the front surface of the eye. Both of those things in concert either say, nope, you're good without glasses for quite a long time, or no, we actually do have to provide you some type of vision correction. So when it comes to both refractive surgery as well as orthokeratology, typically we're taking a curved cornea and we're flattening a little bit, and that can relieve some nearsightedness or some myopia. So with refractive surgery, we're surgically ablating tissue to flatten that curvature. With orthokeratology, we're just using flatter, rigid contact lenses to basically reshape and mold the cornea flatter. So as you can imagine, it's not going to be one lens that gets you there like your very first pair of braces. They're going to need some adjustments, or Invisaligns for that matter. You typically go from multiple pair of Invisaligns to straighten your teeth. Orthokeratology really takes a very similar approach to a course of lenses. You flatten the cornea progressively till you get to the point where it's at its perfect shape, and then you have a maintenance lens, where maybe you only wear it when you sleep, or maybe you only wear it when you sleep every other night or every third night, and that's enough to keep the cornea flat, and you don't need glasses. So there's definitely some art to that, but it can be highly successful, and you basically feel correction-free during all waking hours.
Wow, I have so many questions to ask you, Dr. Lievens, about this, as I'm sure many of our listeners do. First of all, so Ortho K, orthokeratology, is it appropriate only for myopia, which is typically caused by a long eye, but also a lot of curvature of the cornea? Can it also be used for other things like astigmatism or hyperopia or presbyopia?
Presbyopia, probably not. Hyperopia is much more complex, but for typical astigmatism and myopia, that's the lowest hanging fruit, so long as you're starting with a curved cornea. If you're starting with a very flat cornea, then you're probably not the optimal candidate. And so this is just an example where some pre-testing is necessary to help the provider know, all right, how easy is this going to be? And are you really the perfect candidate or maybe suboptimal?
I understand. Thank you for clarifying that. My next question is, when is it appropriate to start? Is there an age at which you would recommend it, or the youngest to the oldest window of time when patients may be eligible for orthokeratology?
So there is some consideration to go a little bit younger today than maybe that we used to think about. And because one of the hottest topics in eye care is retarding myopia, is stopping myopia progression, because myopia has become a worldwide epidemic. You know, I remember growing up in elementary school, and I was maybe one of the 1 or 2 or 3 people that wore glasses. Now, if you walk into a typical elementary school, regardless where you are in the world, pretty much all kids are wearing glasses. It's just very remarkable how quickly this has come on. And so there's some suggestion that holding that cornea in shape in early years could potentially stop the progression of myopia or maybe reduce its pace. And so it used to be I would talk to parents about responsibility and care, but now I'm a bit more aggressive starting earlier because we actually may have this side benefit as well.
So what's the youngest you would consider orthokeratology?
The youngest I've done for contact lenses in general, including orthokeratology, is 4 years old.
Got it.
And
And
so
so
the-
you have
right.
to be taught how to put the lenses in, care for them, hygiene, etc. Right.
Yeah. And so typically, if you have a parent or parents that are contact lens wearers, even if they're not in this type of lens, at least they understand the idea of manipulating the eyelids, inserting a contact lens, removing it, cleaning it. And so if they're somewhat accustomed to it, it's a whole lot easier.
Yeah. And I have to say, yes, there is a learning curve. I've experienced it myself when trying to teach people and watching others putting their lenses, take them out. There is a learning curve to inserting contact lenses in a safe way. But once you pass that, it becomes almost routine. Is that
100%.
correct to say? Yeah. It's part of your, like brushing your teeth in the morning, putting your lenses in, etc. Now, what's the oldest you've ever treated somebody with orthokeratology?
For me personally, we're probably getting into the 30s. It's usually beyond that point where if we're getting too close to having multiple optical needs as we get into presbyopia, then it becomes challenging. And so I try to tackle it at least a decade before that. I predict that's coming.
Got it. Okay, great. So moving on now, I wanted to talk about some potential risks of contact lens use. What are some of the issues you've seen in patients throughout your career with contact lenses?
So when you bring up the whole concept of risk, I really think of severity. Obviously, when your hands are in and around the eyes, it's easy to accidentally have a minor abrasion. Maybe your finger touches your eye, it hurts for a moment, but the eye is pretty resilient. It heals pretty rapidly. We talked about allergy already. Those things are pretty easy to remedy. But the main risk in contact lenses that's still a risk today is microbial keratitis, which has several layers of severity. Because essentially, we're taking fingers and we're touching it to an object, touching it to our eyes. And this is a vector. It's a really bad vector. Frankly, a lot of us aren't very good about washing our hands. And so when we're not washing well, we, via this vector, are bringing microbes to the eye, some of which are very dangerous. And with a contact lens, we can lock those microbes in and really pose the eye and vision a major problem. And so this type of a discussion is really crucial from the doctor-patient relationship perspective, because patients really have to be aware and adhere to hand washing well. And if we do that and we don't overwear contacts, we're typically doing great. But sometimes, believe it or not, hand washing is a big hurdle.
Yes, I've definitely had those discussions with my patients. So you mentioned microbial keratitis. Are there specific organisms that are potentially more dangerous, more risky to the cornea, or more likely to cause an infection?
The number one highest risk is Pseudomonas, in which it's such a robust, powerful microbe that if not treated very aggressively, the whole eye can lose vision very fast. And that's on the antimicrobial side. On the fungal side, Acanthamoeba is as visually destructing as Pseudomonas can be. And then you can have the whole host of other things. If I just scratch my face and put it on a microscope, there'll be staph and strep that just are normal flora. But when this normal flora is allowed to overpopulate, it can also cause gram-positive and gram-negative bacteria that may not be as powerful as Pseudomonas, but still needs to be remedied and killed in order to save vision and maintain ocular comfort.
Yeah, and some of these infections can escalate into really true ocular emergencies. And one of the themes is the adage, an ounce of prevention is worth a pound of cure. And so when it comes to contact lens use and safety, it's much, much better to prevent it from happening than to have to deal with the aftermath of an issue like microbial keratitis. Aside from hand washing, what other good hygiene practices do you recommend for contact lens wearers?
The other things that really come to mind are, number one, do not sleep in contact lenses unless you are in approved contact lenses in which your provider knows that's your intention. And I don't mean accidentally taking a nap for a minute. Intentionally going to sleep on a repetitive basis could pose the eye at great risk. Showering. Go
Dr.
Yeah,
Lievens,
go for it.
there are these, I'm sure you're aware about the brands that are marketed as 2-week extended wear lenses. So
Sure.
what are patients to do with those? They're still supposed to take them out at
No,
nighttime?
no. If the patient lets me know, hey, I want to sleep in my lenses, that's fine. There are FDA approved in the United States lenses in order which that's been proven to be safe. So long
Mhm.
as we have a replacement schedule of which when these lenses are to be removed and either cleaned again or disposed of and a new pair put in, if that's the intent. And frankly, there are people with occupations, firemen,
Mhm.
nurses, overnight shift residents, what have you, where that could be critically important. So long as I know that, I can gear them to the lenses that are designed specifically for that. It's when patients use lenses that aren't designed for that inappropriately that can put the eye at great risk.
I see. Now, what about solutions? I know I've seen, sometimes I cringe when I see friends or family members rinsing their contacts under tap water or using tap water to store their contact lenses in an emergency situation. What are your recommendations for cleaning solutions?
Yeah, so water's a no-no. And so I was about to say one of the things that a lot of people don't know is showering in contact lenses can be a major risk. A lot
Mhm.
of bacteria and fungi can be aerosolized by the shower head. And now you're embarking in this cloud of bacteria and fungus, which can adhere then to the contact lens and actually infect the eye. Swimming in
Mhm.
contact lenses, another no-no. Just steer away from water because we really don't know what's in the water supply, and the water supply is not intended to be paired with contact lenses. One of the largest, if not the largest, fungal outbreak in the world to date happened in the Chicagoland area due to the water supply. And that water was getting in and around contact lenses and caused a lot of issues for wearers. So
Mhm.
definitely stay away from water.
Wow.
Solutions that are designed specifically to pair and disinfect with contact lenses. And that should be the only thing besides the tears in your eyes that ever come in contact with the lens.
Wow. What you said there, Dr. Lievens, was gold. We all have heard, or we talk about not swimming in your contacts, but not showering in your contacts. That's also so critically important. So, Dr. Lievens, we're almost at the end of our time together, but I wanted to ask you, is there any common myth or misconception out there you oftentimes hear from patients about contact lenses that you'd love to dispel today?
Sure, it's that contact lenses are a piece of cake. These things are simple, they're for everybody. I can pick up a pair of colored ones at the beauty store and be fine. And this just comes down to a lot of us take our sight and our eyes for granted. We just assume that we'll be seeing well for the entirety of our lives. But the problem is, none of us know when the issues come up or when they're going to arise. And so, if you happen to be the person in which something happened to your eyes and your vision, and it could have been prevented by just following instructions and talking to your provider and doing exactly what you were told to do, that is a whole lot better than having lost sight because you were the one that chose not to that day. So just follow instructions. Don't go off script. Don't buy contact lenses over the counter. These are your eyes. We only have one set. If something happens to them, sometimes we can rectify it, sometimes we can't. And when we can't, it's a really sad conversation to have.
Such powerful words, Dr. Liebens. Yes, I could not underscore that more myself. I've seen patients, especially around, for example, Halloween is a holiday where in the US where people go out and they buy over-the-counter contact lenses. And those are not FDA approved. Those are very risky. And there are countless of young individuals, even older individuals who've worn these types of contact lenses and unfortunately have had complications and lost their vision. So an ounce of prevention is worth a pound of cure. Thank you again, Dr. Lievens, for spending this time with us on the iHealth Summit and sharing your expertise. If there's anyone who wanted to learn more from you, perhaps become a patient, and also you have a podcast, how could they
I do.
reach out and find more about your work?
So you can email me in my podcast email, which is four-eyed professor, the number four-eyed professor spelled out at gmail.com. I'd love to correspond with anybody that has a question, and I can direct them to where my monthly podcast shows up.
Excellent. Thank you. And we will be including that link in the show notes below. So
Perfect.
again, thank you so much, Dr. Lievens. And thank you all for joining us. We will see you all next time.
Thank you for tuning in to the IQ podcast. I hope you enjoyed today's episode and learned something new to help you boost your IQ. Leave us a review and share the podcast with your family and friends. Stay connected with me for more eye-opening insights on eye health, nutrition, and lifestyle. Until next time, keep your vision clear and your IQ sharp.